Assalamu alaikum, everybody. The topic that I'm going to be presenting today is serum PIVKA II levels in health and disease. I'm Dr. Faryal Hassain, fourth year resident clinical chemistry at Sky Lab Lahore. Now, starting with our topic, what is protein induced by vitamin K absence or antagonist 2? It is basically an abnormal form of prothrombin, which is also known as des-gamma-carboxy prothrombin. Now, it was first discovered in vitamin K deficient patients, or those patients who were receiving a vitamin K antagonist, as implied in its name. It's also known by a couple of other names, for example, protein induced by vitamin K absence, abnormal prothrombin, isoprothrombin, dicuminalized prothrombin, which is an vitamin K antagonist, or atypical prothrombin and hepatoma-associated abnormal prothrombin. Now, in 1984, Liebman et al. First reported it that these PIVKA II was elevated in patients with hepatocellular carcinoma. So it is a vitamin K dependent protein and it is synthesized in the liver, and it has 10 gamma carboxylated glutamic acid residues that are present in its N-terminal end, which is also called the GLA domain. Now, this domain describes its calcium binding properties, which are necessary for its action. Now, this carboxylation reaction is a post-translational process that occurs in the rough endoplasmic reticulum of a normal hepatocyte. However, in hepatocellular carcinoma cells, there may occur a vitamin K deficiency, which leads to lower activity of the gamma-glutamyl carboxylase. And this then results in the formation of this abnormal variant of prothrombin that we call PIVKA II. So when these residues are not carboxylated, they turn into PIVKA II. And this PIVKA II only has 4% of the normal coagulant activity of purified normal prothrombin. Now, this will be more clear in the diagram. As you can see, this is the normal production of PIVKA II, but when these residues are not carboxylated, normal prothrombin is not formed, and instead, PIVKA II is formed. This is another diagram showing the same. This is the normal reaction for carboxylation of the residues. And when this reaction does not take place, PIVKA II is formed. This is again another diagram. This is showing the residues that were not carboxylated. If they are not carboxylated, this is abnormal PIVKA II. And if these are carboxylated, then this is the normal prothrombin or the clotting factor 2. This is another diagram. Okay, so coming to our research paper, hepatocellular carcinoma. Pakistan has one of the highest prevalence rates in the world, and frankly, it's alarming. It is the most common cause of hepatocellular carcinoma in our part of the world is viral hepatitis B and C related cirrhosis. There is a male preponderance to it, and cirrhosis is the most important independent risk factor for it. Unfortunately, in our setup, most of the cases are diagnosed at a very late stage, and when the options for cure are very limited and less than 1% of the tumors are resectable. So screening usually includes both radiologic exams and serological markers such as alpha-fetoprotein at 6-month intervals. There is a paucity of good radiological facilities in areas such as interior Sindh, where there is a high burden of Hep B and C, and hepatocellular carcinoma cases are diagnosed at a very late stage. There's a huge role for biomarkers like PIVKA II in our population for the early detection of the disease. But literature review tells us that this is a study from China. So what they found out was that there is a significant ethnic difference in PIVKA II between the Japanese population and the European population. And this article basically advises us that we should determine our own reference intervals, which is what we decided to do in our research project. So our research project is serum PIVKA II, a determination of the reference interval of healthy population and establishment of its cutoff value for hepatocellular carcinoma diagnosis in Pakistan. This is our questionnaire. Moving pretty quickly because we have only 10 minutes. So this is a cross-sectional study. So we started it in July and ended it in November. We had a total of 239 samples. So we took 120 healthy volunteers as per CLSI guidelines for the determination of a reference interval. And then we had 119 diagnosed cases of hepatocellular carcinoma. The equipment we used was the chemistry auto analyzer LNT1 by Abbott. which uses the CMIA technique, which you are all familiar with. And the reagent kit used was also Alinity PIVKA II reagent kit. We used the SPSS software, and for some analysis, I also used the NCSS software. So these are our results. This is showing the distribution of values in healthy subjects. As you can see, it's a very good distribution. And these are our results. So we basically collected 130 samples, but then we removed 10 values that outliers using the Grubbs outlier test. And our mean was 28.759. Our median was this. And the important thing is our reference interval, which we calculated, was 15.55 to 43.03 milliabsorption units per ml. For our population, it was significantly different from other races. And we calculated it using the percentile method. This is the value of PIVKA II in diagnosed hepatocellular carcinoma cases. As you can see, the distribution is a bit different. And we also determined the cutoff for the diagnosis of hepatocellular carcinoma, again using the percentile method. And the cutoff that we calculated was 148.8 milliabsorption units per liter. And after we completed the study, we also changed our reporting format at TILAB, and we have incorporated our research findings into our reporting format, as you can see in this report. Thank you.